Gonna get started. We are recording this just so you guys know. All right, guys, so today's conference is all about chest pain. I know that Chris Caruso gave you all a great lecture during base camp to sort of think about working up chest pain. And so we're gonna jump into 3 patient cases today where we walk through the diagnosis and management of these patients. So let's start with patient number 1. Okay, so this is from the ER, his subjective complaint. So patient's coming in, he's got a steady gait, he's having left arm pain for a week. He now has chest pain that is 3 out of 10 and aching in nature. He doesn't have any shortness of breath. And he states that he's having increased nasal congestion and non-productive cough. Patient has no fevers, chills, no new leg swelling, no abdominal pain, nausea, vomiting, diarrhea. So this is what he reports when he walks in. Let's give you guys some of his vitals. We will get to his H&P. Or his age and all that. Great question. So here are his vitals that you see as you're stalking the board. Anything alarming there? You can shout out the abnormality. A little hypertensive, but otherwise anything scaring you, just doing his chart check? Little bradycardic as well, okay. And then because you guys are great residents, you scan his med list quickly as well, just to see what you're gonna be dealing with. So I'm gonna drop that in. And so in seeing his med list, does this increase or decrease your suspicion about this chest pain patient? Increase. And what's making you worried?
He's on the capital aspirin stem, so I think he probably is taking stem.
Perfect. So we're worried that this guy has a history. So we're going to pay closer attention to him and maybe think about some of those questions that we're going to ask on our H&P. Do you all?
Can I ask a question?
Yeah, go for it.
Does icosapent cause chest pain? Does anyone have any idea what icosapent is? I don't, for sure. So, anybody happen to know just randomly? Yes.
That's fish oil, right?
Is it fish oil?
Yeah, that's like the prescription.
The prescription fish oil. So, the teaching point is when you see people with random drugs that you've never heard of before, spend a few seconds to look them up, because you hate to be treating somebody for symptoms that are related to a drug that's just not a side effect you've never heard of before. So, all right, I'll look it up and get back to you.
All right, and so you're going to head down there to go see him. Let's get a little more information. We'll make this bigger for you. So here is his H&P. I'll walk through it with you. He's a 64-year-old male. He has a history of CAD, so Claire hit the nail on the head. I'm looking at his med list. He has previous unstable angina or an NSTEMI. He had a PCI with stent placement in December. It's April now. He's coming in with a history of hypertension, hyperlipidemia, bipolar, CKD. He had a pain on the left side of his posterior neck and back, as well as his left arm and chest when he tried to lay down. He states the pain is mostly in his left arm. He's tried icy hot. It helped temporarily, but it still was hurting later. Pain is worse at night, doesn't notice it that much during the day when he's working. And then he believes it's also a little bit positional as well. Then the kicker is that he says he had similar pain when he came in for his MI back in December of 2019. He came in today because this pain is not getting better. Then he's also describing maybe some symptoms of a head cold in the last couple of days. So for those of you that attended Chris's base camp talk on chest pain, do you remember where he talked about likelihood ratios? Yeah, I see Connor nodding, James nodding. Can someone, in reading this H&P and his symptoms, talk about if you have an increased or decreased suspicion for this guy having true cardiac chest pain?
I would say, just to start with, the fact that the pain is worse at night when he's not exerting himself, and if he doesn't notice it during the day while he's probably exerting himself, makes it less likely.
Perfect. Okay, that's great. So James is mentioning, he's feeling the pain more when he's laying down as opposed to when he's active and moving. So that argues against it being typical cardiac chest pain. Anybody have anything else that they're thinking about?
For me, having a past MI.
Him having a past MI, so increasing your likelihood a little bit. Okay, and then are you guys activating the cath lab when you hear this? Seeing Claire shake her head no, James shaking his head no, perfect. Okay, so let's get a little bit more data. So our suspicion is a little high, but we can't really just go off of suspicion here. So I'm going to give you his physical exam. We had his vitals previously. And so here in his cardiac exam, the person who looked at him commented that he's regular rate and rhythm at that time. He's got no murmurs. His chest pain's not reproducible with breathing or positional changes or with palpation of his chest wall. His pulmonary exam is fine. And then for his musculoskeletal exam, he's having some tenderness on his left paraspinal upper thoracic area as well. Any questions on this? Increasing or decreasing your suspicion that this guy is having cardiac chest pain? Decreasing, okay. Seeing some people pointing their fingers down. Anybody think it's increasing? No, perfect. Okay, so let's get some additional information. I'm gonna give you his chest x-ray. Well, I'll take a minute. Take a look at that. And then if anybody wants to point out any abnormalities, I'll pass off the iPad to you. You can draw right on the x-ray. Maybe chat about it with your partner at your table. You can take about 30 seconds and comment on if there's anything alarming that you see.
Sorry. Yeah.
Good, how are you?
Do you need central musculature or? Yeah.
Do you want to make some announcements so that more people just came in about like QR codes?
Oh, I can do it at the end. Just give us a chance to scan here.
Just sit next to me, that's fine. You want them 2 chairs? That's fine.
All right, let's come back together. Anybody have anything they want to point out on this x-ray? Let's do table 3. Leela, Claire, Dante, anybody at that table have anything they want to point out on this chest x-ray? Overall normal, abnormal?
I would maybe something like that. And
Maybe a few interstitial markings? Okay. Anybody else have anything to add?
Looks great. I agree.
Yeah, so overall not too abnormal. I see some wires from stuff hanging over him, maybe some increased interstitial markings. What are some things that you would look for in a patient with chest pain to help with your diagnosis? I heard Dr. Young talking about it with some of the folks over here. So if you were worried about a problem with the aorta, what would be something that you would look for on the chest x-ray? Perfect. Does he have that? No, I'd say it's pretty normal. Okay. Not meaning to trick you guys. Let's move on to this guy's EKG.
Well, Cassandra's pulling up the EKG. I had a patient at Denver Health admitted for chest pain, and it was not called on the chest x-ray, but when you pressed on his chest right here, he jumped off the bed. And if you went and looked at the chest x-ray, he had a very visible rib fracture. And so it sounds stupid, but chest x-rays actually can frequently give you the non-cardiac causes of chest pain as well. So always take a look at them yourself.
All right. And go ahead and take some time. Look at these two EKGs. Feel free to get up close to the screen if you need to. And then in about 45 seconds, we'll come together as a group and we'll have someone read this EKG.
I know some of the students in here are experts.
Yeah.
on reading EKGs, so no pressure.
I gave the old for comparison. All right, any brave soul want to take a crack at commenting on the EKG? I can make his admission one bigger too, now that you've had some time to compare. Thoughts? His labs are all pending, so we'll get those shortly. But are you worried or not worried about this guy? Ben's like, I'll look at you, I'll look away. I don't want to answer this question. Safe space here. I'm not trying to fool anybody.
It's like rate of 60, looks like normal sinus rhythm just based on lead 2, but then has that weird kind of baseline in V1.
Mm-hmm.
Axis looks like it's up in 2 and up in ADF, so I'd say normal axis. Only thing that kind of stands out in terms of the intervals look good. The only thing that kind of stands out is the kind of what appear to be like peak T waves and like V2, V3. They're taller than the QRS, and somebody told me that's sometimes a sign of like hyperkalemia, or that's like a quick test for hyperkalemia.
Yeah.
But there's like no ST depression. No ST
Perfect.
depression, like,
So Ben is hitting the nail on the head. No concerning signs of ischemia on first glance. Let's give you guys his labs to convince you. So these are his admission labs. He has a history of CKD from lithium use, so that creatinine is stable, but otherwise anything upsetting to you all looking at these labs? That should be a quick answer for all of you. Okay, let's take a minute with your partner. Tell me, what do you think the diagnosis is, and how are you going to manage this guy who's getting admitted for chest pain?
Okay, gentlemen, coming in, we've got renal chest pain, positional, and he has a history of neck coming in from your side, and we need to he takes aspirin, Pacalor, Lol, 90% of all, the pain is not exertional. It was at night, labs here.
I like, so he's like, when our chest pain
All right, let's come back together, everybody. So we have a guy coming in with chest pain. The big thing that we have to think about is ACS, right? So somebody want to take a stab at, does this patient have ACS? What's the cause of his chest pain? I saw someone shake their head no to the ACS question. And what are you going to do to fully answer that? Hearing some whispers of things. Anybody want to shout it out? Okay, so the seniors over there are saying the patient does not have ACS. And why are you saying that?
Well, he had a normal stroke.
Mhm.
Not ischemic EKG, so we don't have MI. I don't know what a STEMI or an STEMI. I think we could wonder if he had unstable angina, but I don't think I was convinced by that story enough to see if unstable angina.
Perfect. Okay, great, Claire. And then what would you guys want to do when you admit this patient in terms of managing him? How are you going to confirm your diagnosis or rule out ACS? Heard someone say get another trope. Great. Anything else that you want to do? Okay. So you guys are hitting the nail on the head. We're going to follow his tropes. So he got some follow-up labs. His repeat trope is negative. His A1C is fine for risk stratification. And then we also got a second EKG on him, which didn't look all that different. Baseline's a little bit better. But again, no evidence of ischemia. So.
Does he have chest pain in the hospital?
So he had a little bit of discomfort. It was mostly over palpation of his paraspinous muscles. Okay, so this guy's final diagnosis is non-cardiac chest pain. Not very interesting. Tried to fool you guys with this first one. He was monitored for overnight, and then his tropes were normal, so he left. No changes. Heard some conversation about maybe getting a stress test. His story wasn't that convincing. But let's maybe jump to some patients that are a little bit more convincing or interesting. Yeah.
So when we say non-cardiac chest pain, are we implying it's MSK or we don't know?
Yeah, so his was musculoskeletal. So he was tender over palpation to his muscles, and that ended up being the cause of his pain.
Okay.
Let's look at this other guy though. So we have a second patient. So again, from his ER note, he's walking in, he's having complaints of mid-chest pain that's been constant for months since he was taken off of omeprazole by his oncologist. He was taken off of it due to kidney disease. He says the pain is in his upper chest and medial, no nausea, vomiting, and he just says, I couldn't take it anymore. I came in to be evaluated. Concerned, not concerned? You want to get more information? Yeah, okay, let's jump in. So I'll give you his vitals because you guys are checking his chart to see what's going on before you go down. Overall, how do those look? Overall fine, right? He's a little bit hypertensive, nothing crazy going on there. And then let's give you his med list. He has quite a few more medications than our last guy. So I've tried to highlight some of them that might be of interest to you all for his cardiac meds, but feel free to take a minute and look through. And then as Claire did for the first patient, if someone can tell me, does this raise or lower your suspicion for this guy in terms of him having true cardiac chest pain concerning for ACS? Yes, I can make it bigger. Push it over to you a little bit. Okay. Someone want to take a stab? Do you think he has a cardiac history? What sort of problems do you think he has? Go ahead and shout him out. Hyperlipidemia on a statin. What else could you get from his med list?
Hypertension, diabetes, maybe osteoarthritis.
Great. Any medications on there that you don't know if they would cause chest pain or put him at risk for increased cardiac events? Yeah, lenalidomide. Do you guys know what that is?
No.
Great. It's part of his chemo regimen. And so it can increase your risk for thrombotic events.
What does it do?
It is, let me see, I have that for you here. It's a VEGF inhibitor or an angiogenesis modulator. And so that's how that works. Okay, let's jump down into some more information on this guy. We'll get his chest x-ray if somebody wants. What was that? He has multiple myeloma. Admission chest x-ray. Anything of note there? Is it? Oh, let me get the right one for you.
While this hard to split out, this is actually another really good point about the medication list. Sometimes you'll have a patient who's not provided a history for whatever reason. The medication list will actually be really helpful on you to figure out what medical problems they have. What medical problems do you have? I don't have any. What medication do you have? Methotrexate, alendronate, so look at the med list to help you figure out what they're having.
It is, yeah. I gave you guys the wrong chest x-ray to start, but there was nothing on that other guys. So we've already talked about this one. Nothing here to write home about. Let's pull up his EKG. Okay, so here is his admission EKG, and then his labs are pending. Make it bigger for you all. We unfortunately don't have an old one in the system for him, so we can't compare. Okay, anybody want to take a chance at interpreting this EKG? His labs are pending. I'll give you a little bit more history in just a minute.
The rates are around 70.
Great.
The P waves are there.
Mhm.
Looks like normal sinus rhythm to me. He has a normal axis, I think, positive in one AVF. He has, I don't know if those count as narrow QRS complexes. I would say they're narrowish. He has no QT prolongation. He doesn't have any ST elevations, no early arc progression.
Okay.
And that's, so nothing that I noticed. that's
Okay.
odd.
Yeah, nothing catching your eye to worry about ischemia. Okay. And so to give you guys a little bit more history, he's coming in. He says a couple months ago they took him off of his PPI because of his kidney function getting worse. He really believes that his chest pain is just due to bad GERD. He had a big meal last night. After eating, he felt this burning sensation in the depths of his chest. He took some Tums, he took a ginger ale, maybe it got better, but he's here today with the pain still being present. He really just wants a refill of his Prilosec and to get out of here. But the pain is still sort of coming and going as he's at rest. Any other questions that you guys want answered?
Do the Tums and ginger ale usually help with his GERD?
Not always. So he was taking quite a bit of them, but sometimes he would get some relief and sometimes he wouldn't. So thinking back to the first patient and now to this patient, what's your suspicion in terms of him having ACS, cardiac chest pain? He has diabetes, hypertension, he's on all these crazy medications, he has a history of cancer. And then that's the story that he's giving you, this chest pain that's sort of coming, persisting, maybe getting worse when he's doing things like eating. He's not a very physically active man, so he can't comment exactly on chest pain with exertion. Are you guys worried? Some yeses. Okay, let's get his labs. So here is his admission blood work. So CBC is pretty standard. He's a little bit anemic from his cancer and his treatments that he's getting. But otherwise, his kidney function is normally around 1.2. It's 1.6 today on presentation to the ER, and his admit trope is 0.153 with that EKG. He's still having a little bit of that discomfort as you're talking to him. So much like with the first guy, tell me what you think is going on with this guy, and then what are you going to do to manage him? So take about a minute with your partners, and then we'll pull up the next steps for him.
That's nothing.
Here, you should just go to you guys have to just I think it's Sandra, always right on the radar of So that was our question.
I mean, it could be like a bird, and now it's like worse. I mean, to me, it was just no ST changes. Just being that's the right question.
So many good surprises.
All right, guys, let's come back together. So I have a couple brave souls that are going to walk us through what they think the diagnosis is for this patient. All right, so I have two wonderful volunteers here who are going to tell us their thoughts about what's going on with this patient and what they want to do.
So because the EKG was pretty non-worrisome, like no ST elevation, right? And no ST change, but with a positive trope, we're thinking it's an STEMI.
Okay.
With the chest pain.
So we have some folks worried about NSTEMI, positive troponin, EKG without evidence of ST segment elevation. Anybody arguing for or against that as well? Okay, another vote for NSTEMI. Okay, and then what do you guys want to do for this gentleman?
We're gonna cath him.
Okay, so these folks want to cath. What do other people want to do?
Table 2 has some ideas.
All right, table 2. Michelle's ratting you out. What are you going to do?
We were gonna try to draw some EKGs and then give nitro, aspirin.
Perfect. Try a nitro, give him aspirin. What dose do you want to give him? 325, and then put him on a heparin drip. Perfect. All right. So let me reveal to you guys what else came up on this guy's workup. So that exact thing happened. He got put on a heparin drip. He had his tropes trended. His next trope is a little bit higher. And then we also have his second EKG as well. Anything change here? Are you guys worried about, it being something different than an NSTEMI? Just a quick yes, no. And which lead are you looking at?
I don't know.
Okay. Overall, pretty stable from his past one, right? But as you guys astutely noticed, he's having an end STEMI, so he ended up going to the cath lab. We have some films that I'm going to put up, and then Dr. Morrison is here. He can help us walk through. I'm going to play this and loop it a couple times, and that way you guys can see. We're starting on the left side of this gentleman's circulation.
I'm Justin, I'm one of the interventional cardiology fellows in general cardiology and then vascular medicine, so I know about every vessel in the body. So, you guys said end STEMI in the beginning. I would just be cautious of calling out a positive troponin based on that assay. Positive troponin is above 0.5, so that would actually be considered an indeterminate troponin. Most, that's just me being particular, but if that troponin, second troponin would have been decreased, that would have made it a harder diagnostic decision. What defines a positive troponin is also absolute value, but also the trend. So it needs to come up, it needs to come down. And kind of those curves you learn in medical school when you still see. And so keep that in mind. And also we use 2 different assays across your residency now. You still use a basic troponin I here and use high sensitivity troponin I, DH, and the U. I don't know, do you guys still go to the other hospitals?
We do, yeah.
I don't know what they use, that's where I work. And so it's still the same idea, but percent change means a little bit more on the high sensitivity assay. So I'm sure you guys will go over those things. But anyways, the other thing I wanted to bring up is to define an end STEMI, that's a type 1. And so you have to look at the universal definition of an MI. And so there's 3 aspects of that. One's going to be symptoms, which, so I didn't see you bravely said it was an end STEMI, but you mentioned symptoms. You have an assay that is concerning, it's indeterminate, but we'll say for sake of this argument, it's high enough, but no EKG changes. That's 2 or 3, so that's enough to call it. And when we say type 1 MI, we are talking about plaque. So a plaque rupture or a thrombotic complication from plaque, whereas type 2 is a supply demand. Also be careful of calling something a type 2 end STEMI in your documentation. It actually doesn't exist in the literature and only exists at this institution, which is fine. But if you put type 2 end STEMI on your discharge paperwork, the coders may ask, well, why aren't they on beta block or why aren't they on staff? Because those are quality measures. So just be careful on how you do that.
So we can use type 2 MI, but not type 2 end STEMI.
Yes, type 2 MI for sure, and that's that's in the universal definition. But if you put type 2 end STEMI, that might come back to you, or it'll come back to us, or not me, or not general fellow, but the attendings have to adapt that. Okay, so now I'm off my soapbox. Let's look at the major again. So this is the left side system for you for the second or third years in here. I'm sure you've seen it here now as you can for cardiology. Oh wow. So you have your left main, so that's kind of the big artery that our catheter is engaging. And what are our 2 branches off the left main in a normal anatomy? We're not going to get with general. LAD and the circumflex. Okay. And so in this particular view, I'm not going to go over like different RAO model and all that. So we can do that during the rotations with us. But the artery that's coming straight down, so this guy here is your left circumflex. And then this guy that's kind of wrapping around the front side of the heart in the interventricular septum is called the LAD. Okay. If you're not sure and you look closely, we'll play through here. On the LAD, you see these arteries coming perpendicular, diving kind of into the screen. Those are called septal branches. And that's what defines an LAD. Because the LAD courses through the interventricular septum and supplies the septum. So that's why when you use an LAD, you'll have septal EKG findings, septal wall motion abnormalities. The other artery that we'll see here in a second that supplies septals is called the posterior descending artery, or the PDA. That defines dominance. So there's only 2 arteries. If you see something with a septal, I would just say it's the LAD. That's going to be what you guys see most of the time. More importantly here, do you see anything that looks funny? Remember, an artery should be a nice cylindrical type 2.
or a pipe. And it should look the same, just get a little smaller as it goes farther down the heart. So do you see any abnormalities, anything that looks a little funny? Yeah. Yeah, exactly. So, how do you, I see. Yeah, how do you pause that? Oh, perfect, that works. Okay. So in the course of the LED, I put a still frame here. You kind of see it really well right here. Whoop. Oh, okay. Sorry, I got it. So that is a stenosis. And, we don't have, when we just look at the angiogram, we say the percent stenosis makes us look really smart. But this is severe. I mean, if you look at the caliber of the artery just before and just after, you can argue that it's at least greater than 70% blocked. That's also in the proximal LED. And so what defines proximal LED is where the septal comes off, the first septal. And so that is one of the highest risk regions to have disease. And so this is a significant lesion. He's coming in with an end STEMI. And so we don't need to do any other testing. You don't need a stress test. You don't need anything else. This is an ACS syndrome. So we would fix this, which I know we did.
Okay, so let's get a little bit more. We can also look at his right-sided circulation.
Yep, so we're always going to look at all the arteries before we fix anything. We need to know the anatomy. So this is the right side. So we use a different catheter to get into the right coronary artery. And so in this particular picture, pause it in the middle again. I want to just show you one thing. There's a little bit of disease in the proximal portion of that vessel. Is this vessel at the distal end, so towards the end here, is the PDA, okay? And so if we played it through, you're gonna imagine, just let you know they're there. There's septal perforators coming off of that. And so this is what we call a right dominant system. Okay.
All right, and so as Dr. Morrison mentioned, we got to fix this. So let's see what they did to fix his lesion. All right.
This is the LED MRC, right?
Yeah.
Fixed.
Yep.
Okay. So I'm not going to get into the specifics because that's more of like a fellow level. But the lesion that caused his end STEMI was the LED lesion. Okay? It was more severe. It's in the location by the angiographic look as well. It had a little more haziness compared to the RCA, which suggests there was some sort of thrombus formation. And when we looked on the IVUS, which is ultrasound inside the artery, we saw some thrombosis. Since he's there, he's doing well, stable. He had significant disease in the right artery as well, in the proximal portion. We fixed that too. And also the interventionalist who was here at the time was very aggressive, so he fixed everything. But you could have argued to fix the LED, that had to be fixed. That would be malpractice, not standard of care, not to fix that. You could have argued since the RCA was at 70%, maybe medically manage. Let me ask you this question. With what we just did for him, so he got PCI, had an end STEMI, we fixed him. What long-term benefit is he going to get? Is he going to get a mortality benefit? Is he going to get a morbidity benefit? So the seniors, correct? So why do you guys say that?
He doesn't get a mortality benefit if he's, I think some people would argue that maybe if he's optimally medically managed and still having symptoms on top of that, maybe he get a temporary morbidity benefit, but he might, well, the studies, I think, don't show a long.
That's correct. So the only, these are subset populations. Obviously, cardiology studies are massive compared to most disciplines. So we can do all these subgroup analyses. Is if you look, there's only a short-term mortality benefit in high-risk end STEMI. So that's somebody who is in cardiogenic shock despite not having a STEMI, but is having an end STEMI, LV dysfunction, or electrical instability. If you take those patients to cath and revascularize, they'll have a better short-term mortality compared to the other population. But if you still go out 5 to 10 years, there's not a statistically significant difference in mortality. And so I'm biased because I'm an interventional fellow, but we really have to think, is it worth having them undergo the risk of an invasive procedure to fix something? Normally, yes. But, you know, with the recent studies that came out over the last year, especially in stable angina, you know, you have to just ask yourself, is it worth the risk of the procedure in an end STEMI?
Awesome. Questions on those films? Okay.
Perfect. You already have the,
And
so
so-
that indications for urgent angio is where we see those short-term benefits,
Mhm.
mortality benefits.
So you guys hit the nail on the head with NSTEMI management. If they're hypoxic, please put oxygen on them so that way they don't, you know, have a PEA arrest of hypoxia. But otherwise, getting them on a beta blocker, a high intensity statin, antiplatelet therapy, giving them their heparin drip, and then calling cards for an angio is the right thing to do. And then down at the bottom, you can see the indications for a more urgent angio. So your patient's doing fine with their NSTEMI, but then they start developing VT on the monitor. You call cards because they need something to be done more urgently.
And we need to know about these patients, but unless if they're unstable, you guys can manage them for a little bit. I don't, you know, when I was a general fellow, I did not need to be called the instant they came into the hospital. A lot of times it was the ED at DH specifically, but you know, this is within the realm of internal medicine, is managing a low risk NSTEMI. So, you know, if they come in, if you're on cards call or whatnot, you know, bring them in. If you think it's an NSTEMI, you don't need to call me to ask if they need heparin, unless there's some concern that they have a bleeding issue, that then yes, we'll be happy to help. But get them on heparin and, you know, medically manage them with beta blocker, get them on a statin, aspirin. At this particular institution across where you guys are, or at least the 3 hospitals I work at, we do not load with Rollin or clopidogrel in the ED. And the reason being is if they need surgery, our surgeons will not operate on them with that on board. Where I went to residency, we did. That's the culture here. So just to let you guys know.
Okay. All right. Questions about this guy?
Does chest pain get better?
It did.
So
Yeah.
it's sort of an atypical month-long duration for like a prox LAD, like a clean, so you got better.
It was very atypical. The resident who admitted him, me, was fooled and was like, oh, maybe this is not really like a big deal that we have to think about. But then he went to the cath lab and had this disease. Only other major things for him is that his lenalidomide for his multiple myeloma, as we brought up, is prothrombotic. So a courtesy FYI to oncology when he's discharging so they can change his regimen is appreciated. So that's what they did. Let's go to our last guy. We're
I
gonna
have a
move.
general question.
Yeah.
Is there like a one-liner to understand why would there be no ST changes versus a STEMI versus not STEMI? Like what's physiologically happening when there's no ST changes?
So the best time to get an EKG is during chest pain. And the reason behind that is when you have chest pain, you're having some sort of misbalance of oxygen demand, of oxygen supply and demand, even in a type 1. Just a mechanism that differentiates type 1 and type 2. So it's actually tough to know, you know, in these cases, you know, when we talk amongst ourselves, was he actually having a true NSTEMI at that moment? He might have always had a little bit of troponin with his underlying multiple myeloma, his chemotherapy. But in order to continue his chemotherapy with that angiographic finding, he has to get it fixed. You know, oncology would call us and say, you need to fix that in order for us to offer him chemotherapy. Because a lot of those agents, as you know, you guys will see, even though they may not be directly, it's hard on the body and causes demand. And so we get a lot of patients who are about to undergo chemotherapy for revascularization. A lot of them get stress tests, depending on what chemo they're going to get, you know, MAGAs, and I don't know what they use. That's what we use in my residency. But and so that's the other indication. And you know, if you look at sensitivity and specificity of EKG changes, it's not 100% by any stretch. It's just like anything in medicine. It's high, but it has to be in the correct clinical context. So just because they don't have the EKG findings. And lastly, that's why EKG findings is one of the 3 things to define an MI. It's not a must. It doesn't have to be there.
Okay, so we are running out of time, but I want to get to this last case. So patient number 3 also came in. He's having substernal chest pain. He's got a little bit of a headache. And then it's the theme here is that he also says, I ran my reflux medication. This is why I'm having chest pain. So I'm going to come in. You scan his vitals. There's nothing really alarming there. For his medications, fluoxetine, omeprazole, and pravastatin. So nothing major on his med list either. Maybe some hyperlipidemia without pravastatin. And then for his history, we have a little bit more information here. So he has a history of bradycardia. He's had a pacer. He's got GERD and hyperlipidemia. Pain started 2 days ago and he received an upsetting phone call. Otherwise, it was severe, but he slept well that night. The pain returned last night prior to coming in. It's been constant. Bilateral anterior chest. It's pressure-like, associated with nausea, no diaphoresis, no shortness of breath. It is not worse with walking, according to him. He's 4 out of 10 currently. No abdominal pain, no fevers, nothing else. So are you guys worried about this guy?
Yes.
Yes. Let's get some more information.
It's the third case, it has to get worse, right?
I mean, maybe, who knows? So let's get some labs on him. So ER is checking a lipase, making sure it's not pancreatitis. Everything here is pretty stable. His creatinine was about that prior. Any questions on that? Okay, let's,
AST elevation chronometer.
that's new. So,
Keep that in mind. And at the end of the case, I'm gonna ask you why it's that high.
okay. So he has an old EKG in our system. I'll give you guys a second just to look at it and appreciate what this is looking like. Anything major there? That's just poor baseline. Okay, we're not gonna spend too much time on that. Let's get to the money. So here is his admission EKG. This is a tough one. Take 30 seconds, a minute with your partner and talk about this EKG and your thoughts about it.
He has low voltage currencies throughout, which is
Yeah. I think this one.
Is this the last EKG you have?
Yeah.
Okay.
I feel really blind in here. I can see. Yeah. I'm like. Yeah.
Sorry, I'm touching because I'm just screaming. That's okay. I'm really sorry. I just realized it's not my computer. I'm so sorry.
All right, so this one is a little bit tougher than the last couple. Anybody notice anything abnormal about this EKG they want to comment on?
ST depressions in 3 and 4, V3 and V4.
And what does that mean to you? Why is that worrisome?
Because it's depressed.
Yeah, it's depressed. Anybody else want to jump in and help out? Any other thoughts? So it's abnormal, not normal. What if I also gave you this? His troponin is 73 with this EKG.
So what's your differential with V2 through V4 depressions? There's two things that you should think of when you see that in someone who has active substernal chest pain. Even though it's across the precordium, it's still typical angina and a troponin of 73. So what are the two possibilities from that? So you think this is an ACS? Yes or no? Yeah. Okay. There's three components to an ACS. There's STEMI and STEMI and unstable angina. It's not unstable angina because it's EKG and troponin conduits. Okay. So what your two options are: a STEMI or an NSTEMI. What kind of STEMI could this be? Yeah, yeah, I hear some whispering. So if you think of it the opposite way, they're tombstones or they're elevated, you're thinking the anterior MI, right? So the exact opposite would be a posterior MI. So that's one consideration. And you still think of an NSTEMI. This is a hard case and the fellow missed it. It happens, I've missed one MI in my time. You don't do it a second time, but you do it. And so this is really concerning. So somebody who's having active chest pain, I don't know what they did in the ED, probably not much here, but if they did, that'd be great.
No, they put him on a heparin drip. They gave him some nitro. His chest pain improved slightly with the nitro, but not totally.
Yeah. So continued chest pain with maximally tolerated medical therapy. That's a high proponent. You're concerned, and with those EKG findings, when I went and saw it, I said this is a posterior STEMI.
And
so you call the fellow if you see that or you're worried. This is the time where if you see something on the EKG, something in the story, can't speak not all fellows are created equal, and they may not all be as nice. But if you called me with that, I would never give you a hard time because that is concerning. And I would have went to my attending and said, like if I was the general fellow at the time, I need to call the interventionalists.
Do you expect any changes in ABR?
No, not necessarily.
Okay.
You want it because it's actually depending on the anatomy of the person. So what vessel actually is it? It may not affect ABR because the electrical forces might be perpendicular to ABR, and so you're not going to get any changes.
But a good point that Linda brings up is where the reciprocal changes. You'd expect to see ST segment elevations and 2-3 AVF. He doesn't quite have those, but he does have some Q waves that have formed. So that's maybe another clue to you all. This is a true posterior MI.
And if you saw this, what can you tell the ED or whoever where they're at to do next? Outside of maybe activating the cath lab. This is like, what am I thinking of? But this is actually really important. It can be on your medicine boards, not just cards boards. You can do posterior EKG, right? B7, B8, and B9. They go across the back. And so you would get Q waves on there. And so they should have done a post. I don't know if they did or not.
I think they did, but it wasn't in the chart. So
it's sometimes in the chart, but they don't mark it's posterior, so you have no idea what you're looking at. But this is the time where a posterior MI, and that could be a potential question on medicine boards.
okay, so he's put on heparin. He was given nitro. He got his aspirin and his statin. Cardiology was called. They were concerned. Took him over to the cath lab, and then this is what we saw in terms of our pre.
Yep, so left side of the
I'll
system
loop
here, LAD. So when we're going for potential STEMI, it is a little more advanced because you're not looking for something that's there, you're looking for something that's not there, right? So that's a total thrombotic occlusion. So if you want to trust me, the left side looks good. There is some disease in there. We ended up fixing a few things after the fact, but the left side's fine. So now we're worried about the right. And so if you look at the right, this is really hard to see, but the PDA is completely missing. And it's hard. Right there, you can see a wisp of something it's stumped off. So the PDA comes off for about 1 to 2 millimeters and is then thrombotically occluded. So I can go to both sides, but you can keep playing that.
Yep.
Right here. You see a little bit of haziness where something should be coming off. There's nothing there. And then for you guys over here. So there's, you kind of see a little bit of wisp of something, a little bit of haziness, but that's obvious. And so we fixed it.
Okay, so let's look at his post, and we will wrap up and get you guys out of here. I'll put them side by side so that way you can see the difference. So hopefully you guys can tell that now we have this whole vessel that is lighting up that was not lighting up before. You guys see that? Okay. Questions about this?
And the flow is a little sluggish compared to the PL that's right above it. That's just what happens when there's thrombus in the vessel. That will go away with TICAG. That's one of the benefits of giving the P2, a potent P2 on 12.
Okay. Questions for Dr. Morrison before he heads out back to the cath lab?
Is there any significance to like it seeming like his QRS complexes were like kind of low voltage, like on the last EKG? It just didn't seem that high. Is that significant at all?
If it was diffused throughout the entire EKG, then you worry about effusion or RB failure. So one of the most, you'll learn this in pulmonary hypertension, as well, a bad prognostic sign of RV failures, a pericardioid effusion. So if this was an old, let's say they came in 3 days later, that tells me he's probably in complete RV failure and they're likely in cardiogenic shock. But outside of that, usually it's technique of the actual EKG.
Okay.
Yeah.
Kind of going back to the history, we're classically taught that improvement with nitro is a sign of like cardiac chest pain. What's like the one-liner for cardiology about using that diagnostically?
Yeah, so the classic teaching is somebody who has a STEMI should not get better with nitro because nitro is a vasodilator. If your vessels are acutely occluded, it doesn't matter what you do, right? That is true most of the time, and that's actually how I missed my MI. I was in a case at Denver Health doing a leg, called me down to the ED, had typical chest pain, gave nitro, got better. I was like, oh, we're probably okay. Next troponin, when it was before high sensitivity, was like 1 and then 150 or something. Brought him right up and he had a Prox LAD STEMI, unfortunately. So you just have to be careful. It's reassuring when it goes away, but again, in medicine, as you guys know or will learn, nothing is absolute. And so, in an end STEMI, that's great. You want to give nitro, you want to get them chest pain free, and that's when it's concerning.
Do you see non-cardiac chest pain get better with nitro?
Yeah, there is a placebo effect for sure. I mean, obviously esophageal spasm, that's a important type question, but a lot of times I think it's a placebo effect because we see it all the time. There's someone in patient right now who keeps having these chest pain episodes. You give him one sublingual nitro and he gets automatically better. That's probably very unlikely true in anginal pain, and there's probably a placebo component to it.
Thank you for coming.
Yeah, thanks. I'll see you guys around.
Wrapping up just a few quick teaching points. So STEMI management is almost identical to NSTEMI management, with the exception being their angiography has to happen ASAP. 90 minutes, door to balloon. As a senior, when you're on overnight in the CICU, you're going to be asking yourself the age-old question of, do I give them their beta blocker or not? Do I wait? And so the KILLIP classification is something that you can use. And it basically has to do with evidence of heart failure on exam. So if somebody's STEMI is so massive that they go into cardiogenic shock from it, you don't want to give them a beta blocker. But if you have KILLIP classification 1, no evidence of heart failure, it is okay to start them off on something. Always ask your cards fellow if you are worried or afraid about starting that. And then our value pearl for this talk, things we do for no reason, trending all troponins to peak. So you should trend it in ACS. So as with all of our patients here, we were concerned about ACS. We had to rule it out. So you should be trending to peak. And there is some literature that will tell you that the STEMI infarct size is correlated with the troponin peak. So that might be a reason why your cardiology attendings are asking you to follow this. It is important to be judicious about it. So the cost of trending a troponin at the university, remember all these values from this year will come from the U, can cost anywhere from $140 to $370 per test based on the type of troponin lab that's going on. And so just be mindful of that. If your patient is coming in septic shock and they have a slight trope, it's probably due to their demand from their severe illness, not due to an actual occlusion if their EKG looks fine. So just keep that in the back of your mind. Maybe be a little bit mindful about when you're ordering these tropes if you truly have or do not have a clinical suspicion for ACS. Questions on today's talk? Okay, so now you guys will know the difference between NSTEMI and STEMI. You guys have seen some cardiac cath lab films to get a good handle on where the lesions are actually occurring. We reviewed our NSTEMI and STEMI management. Any questions at all, please feel free to ask and let me know. Otherwise, I'll be sending out an email with all of the boards from this week's talk, so you can go back and review. And then lastly, if you scan the QR code for today, it'll be the same link every day. It just helps us track who's coming, who's not. And then at the end of the month, we'll play trivia. And if you answer the questions, I can get you a better prize that you would like. So answer the questions every day and we'll get you something if you win trivia.